one. Good afternoon, everybody. My name is Eliana Cloutier, and we have Corrin Shores, and we are going to be talking about Guillain-Barré syndrome today.
And yeah, if we were in class, we'd have you all pronounce Guillain-Barré, Guillain-Barré. So practice at home.
All right, so we are going to go over the learning objectives, some general background information regarding Guillain-Barré, etiology and causes, some of the characteristics and symptoms to look for, the types and phases. We will get a little bit more OT oriented, talk about an evaluation that we'll be doing, interventions, and some precautions, contraindications with the syndrome, and some other treatment approaches and our goals. So a couple of objectives we want you to understand more about Guillain-Barré. I feel like it's fairly common enough that we should understand, but I think a lot of people also to look at this syndrome through an OT lens and decide the best course of treatment when working with these patients, and then how to apply this knowledge and create, OT specific interventions in different phases of recovery.
So again, if we were in class, this is where we would have you participate in a Padlet just so we refresh what we've learned in past classes. If you would like to do this at home, please feel free to. Just scan the QR code.
Okay, so Guillain-Barré is a syndrome. It's considered an autoimmune disease, and it is where our own immune system attacks the myelin sheath. And so you can see this neuron here. And the myelin sheath, we have it in the yellow box you can see. And so that myelin sheath wraps around the axon cord. And when this myelin is attacked and is stripped away, our nerves cannot conduct signals. And so that is why you see people, they have complete flaccidity. They usually have sensation issues. And it's due to that myelin sheath no longer being. And here is like I said, that last picture was what a whole healthy neuron looks like. And this is what a neuron would look like if it was affected by that autoimmune disorder of GBS. And you can see the exposed nerve fiber there and the damaged myelin sheath. All right, a little background information about Guillain-Barré. It is an acute, rapidly progressing inflammatory peripheral nerves and spinal nerves. And as I said before, it's an autoimmune disease. 2/3 of the cases follow an infection, more bacterial than viral, but it is rare. Also, vaccines have known to trigger it, and as have surgical procedures. There are 4 different variants. The most common is going to be the rapidly progressive ascending symmetrical muscle weakness, and that is called acute rapidly progressing inflammatory demyelinating polyradiculopathy. Say that 5 times fast. And that's about 85% of the cases, I believe. And it's not too common, roughly about 3,000 to 6,000 people affected in this. The prognosis is pretty good, and most people spontaneously recover in conjunction with a couple of treatments that we'll discuss later on in the presentation. And so it does have a pretty good prognosis. Now, 20 to 30% of the 85% will experience significant residual, I would say mild residual impairments with sensation and motor control. Then, as you can see, significant long-term lifelong impairment, and about 5% result in death. And that is because GBS can actually go on and affect your lungs and your breathing. And if that's the case, a lot of people with GBS will face potential ventilation.
And the death is from like aspiration or pulmonary embolisms and things like that that is secondary to the diagnosis.
And so I kind of said there are no known causes or cures, but we have just noticed a few triggers. And like I said, a lot of times, say about 5 days to 2 weeks following a severe viral or bacterial infection, these GBS cases will arrive. Surgical procedures. I had a friend who had this. She was 50 and she went in for routine surgery. There was no issues. And then a couple weeks later, she exhibited symptoms of GBS, and surely that's what it was. Then vaccine is something else that has been documented, but once again, super strong correlation there. And getting the vaccine has proven to be a safer option than not getting it when considering the possibility of getting GBS, and then toxin exposure, but that's a little bit more mild. All right, so a couple things to look for when assessing someone for GBS. You're going to see that hallmark symptom, which is a rapidly ascending symmetrical muscle weakness of both extremities. So that usually goes from you're going to start feeling pins and needles, some numbness, some pain. They call it a stocking glove sensation, where it feels like you're wearing tights that are too tight. And it's traditionally bilateral, like you're not going to have it in just one foot. You're going to have it in both legs, both hands, and then it keeps going inward towards the trunk. And then, so like I said, the initial sign people feel is that skin crawling, pins and needles, tingling. And then depending on how far up the demyelination occurs, you'll start seeing some issues with breathing, swallowing, blood pressure, heart rate, and we call it this autonomic issues. And these things, like I said, are all the stopping of these, like your swallow and blood pressure. Those causes are secondary to GBS.
And we just want to point out that this is mostly in the acute phase. So right after the infection or whatever triggers the disease process, this is the symptoms and characteristics that they are going to exhibit. And then also the performance issues that's going to affect every aspect of occupation.
Right. So like I said, there are 4 different types. The most common is going to be that acute, we call it ADIP. And I said 85% roughly of GBS is going to be that. And that's that bilateral. And then there's also one that it just affects the motor axons. And so you'll still have sensation, but you're not going to have your ability, no motor, no tone, very flaccid, no spasticity. And then the other one's pretty rare is a Miller-Fisher and the acute motor and sensory. That's when it affects both kind of alternating. And then traditionally with GBS, you are going to get your main symptoms within the weeks, sometimes less than 4 weeks. But basically that acute phase is going to be no longer than a month. And that's pretty rare. Even at that 2 weeks is when it usually tends to, like, you'll see the max effects of your Guillain-Barré, and then you plateau for about 3 to 6 up to 3 months. And that's where you're probably not going to, you're going to maintain that level of paralysis. And then about month 3, you're going to start regaining some of your motor and sensory. And here is just a nice scale to kind of see. If you look to the left side, you'll see the no weakness to paralysis. And that's like starting like negative week 4. And then by 4 weeks from the initial onset of symptoms, you're not going to be getting any worse. You're not going to see anyone getting any worse. And if they are, that is a different type of neuropathy. And that's going to be more long-term and usually a lot more. And so you can see this infection peak in the course of GBS is that green line on top. And then the anti-ganglioside antibodies, that's basically just your immune system attacking itself. And those are those antibodies that are going to be doing that.
Okay, so we kind of broke everything up into what you would see if you were an acute OT, seeing someone in the first 2 weeks with their course of GBS, and then as as if you were a post-acute OT, and what would that look like with their symptoms and things. So they may not be able to speak, so you may have to give the caregiver their occupational profile, how they were before their infection, their syndrome. And then again, just you can use a verbal pain scale if they are just the facial grimaces of aspects of their care and what you're doing. And then skin assessments will be very important because, like Eliana said, they are mostly flaccid in this stage. So seeing how if they have good skin integrity and make sure they're not forming ulcers, and then also that passive range of motion, because they don't have active range of motion, but you want them to keep that movement. It's not develop contractures or anything that goes along with being flaccid in bed. And then more on the post-acute side, so this could be kind of at the end of the plateau into the recovery. You would do an occupational profile, the patient, client, probably more of a verbal pain scale at this point. And this is where we'll be able to do a sensory assessment to see if they're still having any residual sensory impairments. So we would definitely do light touch, sharp, dull, hot, cold, safety assessments, as well as proprioception, so where the body is in space, and hopefully everybody remembers how to do those. Skin assessments are still important in this, as well as passive range of motion and the active range of motion at this time. We may be able to do MMT. They not be able to hold resistance against gravity, so you might have to remember those gravity neutral assessments. And then also home assessment was conducive to their environment, that their new life and fighting this the symptoms. And then also an ADL assessment to see how well they're able to take care of themselves and do the things they need and want to do. So again, in the intervention, we kind of broke it up into both of these, acute and subacute. So in an acute, if you're in the hospital with someone with GBS, our three main things we talked about and we found important were preventing contractures, DVTs, and ulcers, safe transfers, and pain management. So when we're preventing those things that come along with being stationary, being able to move ourselves, we would instruct the caregiver or the client, if they're able, on repositioning every 2 hours, skin checks, bed positioning, passive range of motion, and probably a resting hand splint for orthosis. And then for safe transfers, we would definitely instruct the caregiver on safe body mechanics for aiding their loved one and getting to and from the bed, and then as well as the client on those cues. And then for pain management, talk about PAMs and such as desensitization strategies and things that would help reduce their pain. And then in the subacute category, we would more focus on things that getting back to their prior way of life. So fatigue management is something a lot of people face. So how to modify their tasks when they're still having this generalized weakness because they've been flaccid for 2 to 6 months, yeah, depending on the progression of the disease. And also assistive technology that can be appropriate for compensating weakness. One big one that we've found is the elevated arm splints. Is that
the mobile
arm splints that are just reduce that gravity, like we talked about earlier. And then obviously, you have something?
Whenever you're done with this,
the therapeutic exercise. So active assist range of motion to active range of motion to resistive exercises definitely would help someone get back to where they were before. Home exercise plans, implementing those, and then PNF. So those movements shown to help with people with GBS recover and regain those movements faster. And then also when we're doing these, we need to watch for muscle compensation. So if they're having residual shoulder weakness, they may punch forward and help them in the long run. And then very, very important, prevention. So balance strategies, both dynamic and static, home modifications to make sure there's nothing tripping hazards or anything like that. Again, with conservation strategies, so they're not pushing themselves and getting tired and falling, as well, including and also AFOs as an orthosis.
Yeah, just to add a little bit to that, due to their flaccidity, a lot of these individuals will present with foot drop, and so they can't keep their foot in any sort, do any sort of dorsal flexion. So AFOs are really helpful when educating on like fall prevention and transfers. Another thing to look for is muscle belly weakness or tenderness, I'm sorry. And that is one of the longest lasting symptoms of GBS. And important during this subacute time that we are very cognizant of fatigue because pushing through these can actually prolong their symptoms and delay their recovery. And another really important thing to highlight about Guillain-Barré is that there are no cognitive effects. So these people are still, their cognition is 100% intact.
Yeah, the only really cognitive symptoms they may experience is anxiety and just stress about recovering. Because, I mean, imagine if you're in bed and not being able to move, but you're completely aware of all the things that are going on. And then us going off of the muscle belly weakness is very important when we're doing these passive and active range of motion, not to overstretch the muscle bellies, because that for these things that could cause the very serious complications such as dysphagia and aspiration. So working with our interdisciplinary team on that, and just being aware if they are getting able to feed themselves, and that we're having them in proper positioning. Very important to think about is the intense pain that they're feeling, as well as the muscle belly tenderness and the fatigue. And like we mentioned earlier, contractures, bed sores, DVTs, falls, anything that goes along with being in a bed for a long time. And then in the subacute precautions and contraindications, it's very important that we still continue to monitor vital signs, and we ensure that there's no further damage to the nerves, and that would come from overstretching the muscle belly tendons, and then as well as strains and sprains, which happen with overcompensating. And then also if our muscles are weaker, we're not able to support our joints as well. So if we try to overdo it, then our ligaments and tendons will have to compensate, and then that's when we get the secondary outcomes such as sprains and strains to the joints. So we came up with one long-term, short-term goal for each phase or types of phases. So we have in our acute that a client will complete stand pivot transfer at edge of bed to wheelchair with mod assist for safety during toileting within 4 weeks. And then the short-term goal is client will recall biomechanical cues for safe transfers, edge of bed to wheelchair with independently within 1 week. And then for subacute phase, so maybe in a inpatient rehab center or home health, client will complete full body bathing routine with mod independence, demonstrating 4 out of 4 energy conservation strategies in 6 weeks. And the short-term goal being client will recall 4 out of 4 energy conservation strategies independently within 1 week. So we're really focusing on the transfers aspect of the acute side, and then ADLs and energy conservation aspects on the subacute side. And I do like to mention that we thought really hard about the timeframes for these goals. So we wanted to think about the acute phase and how long they will be in that acute phase, and then also in subacute and making it a little longer. So they can account for all of the other aspects that they're going recovery process.
To add to that, a little bit about, because Guillain-Barré is such a spontaneous disease, there are no known causes or cures. We're just kind of along for the ride, and a lot of it is like supporting these people during this time. A lot of people, you can be completely healthy, and 2 weeks you're completely paralyzed. And so a lot of it is just kind of like we are trying to maintain like a positive mindset, and also like we are working with these clients long term, but not for a long-term illness, hopefully, in theory. Whereas like someone has a stroke, they're most likely going to have residual issues for, the remainder of their life. Whereas someone with Guillain-Barré can have a really hard 6 months, and then maybe at 2 years, they've made a full recovery. And also, if y'all want to offer any input on our goals, we would love feedback.
Yes. And then also we'd like to mention some of the other treatment approaches that wouldn't be from OT. Plasmapheresis is a kind of similar to dialysis, where you're taking your blood from your body and filtering it, but you're taking the whole blood from the plasma in your blood and returning the whole blood to the client without their plasma and with like a plasma replacement. And this actually helps to decrease the acute phase because they're no longer having as much as the autoimmune effects. And then the intravenous immunoglobulin, excuse me, is an IV injection that has high doses of protein that is given to a lot of people when they have immunocompromisation. If they're immunocompromised.
Yeah, basically. Okay. Yeah. Basically, the plasma, we're pulling out their reactive antibodies and replacing it with just like an inert fluid. And then with the immunoglobulin, we're actually giving them the proper antibiotics needed to fight. Yeah.
Yes. So, and then also we like to point out the interdisciplinary team, which you would definitely be seeing in all phases of GBS, which would be the medical doctors, neurologists, neuromuscular specialists, psychiatrists, because of all those psychosocial effects that we talked about, respiratory therapists, especially if they are on a ventilator or any types of breathing complications, a cardiologist, especially if they get put on ECMO or anything that would help them with breathing and their heart functioning. And then also all of our therapy people, our PT, OT, speech, and then client and family. And we also said et cetera because it could really affect a bunch of range of medical complications. So we didn't want to limit it to just that. And here are our references. And then we also have a wonderful, lovely Kahoot. And we left it open until April 8th. So if you want to refresh at any time, it should be available. The link is up here as well as the QR code. And that is all.
We'll go over our other forms now.
Yes. So here is our, I'm trying to make it full screen really quick. Our provocative tests. There's not really a provocative test for GBS, but we would like to go over some sensation assessments. That would be very important. You should all recognize these three because we have learned them in neuro, was it? I think it was neuro. Yeah. So definitely light touch, which you would do on both of their arms and all of the dermatomes, and then sharp dull pain. So using that safety pin to see if they just can discriminate between the sharp and the dull sensation, and then hot and cold temperature discrimination, which is using those hot and cold prongs and seeing if they could say if they're hot or cold. And all of these are very, very important for safety in different ways, especially ADL safety, hot and cold discrimination with bathing and cooking, and light touch and sharp and dull with navigating their environment and fine motor skills, making sure they're not getting hurt. Oopsies. Come on. Okay. And then our Pam.
All right, and so we chose flutotherapy because since these people usually are paralyzed or they have very, very limited amounts of movement, flutotherapy is something that we can set them up with and monitor them. And it promotes circulation, and it can also help with desensitization. And so because they have this demyelinated sheath and their nerves are exposed, a lot of people with Guillain-Barré can experience a lot of pain and a lot of kind of vacillating, sensory issues. And therapy can really help with desensitization, which is why we chose that. We are all familiar with flutotherapy at this point in time. So just a little bit about it. It utilizes a dry cellulose medium, usually corn husks, and it's circulated in these arm portholes, and the air is regulated on the warmer side to about 105, 118. And like I said, this, I've never seen anyone use a phototherapy machine on their legs. Maybe it can be done. I don't know. But traditionally, we do this with the arms. And like I said, it increases temperature of the arms. It provides a sensory effect for desensitization. And then that pressure oscillations, this would be maybe something for a little bit more on subacute when they do have a little bit of movement back. Can be doing exercises with their hands in the machine to improve circulation and edema management. And so method of application, we need to turn the machine on ahead of time. It takes roughly 45 minutes to heat up. And then we need to adjust the blower to the desired temperature and blow speed. It is imperative that we don't put anyone in there that has any wounds. And we also need to remove any jewelry because it can get hot and burn them. And then treatment time is usually about 20 minutes. A couple precautions, contraindications, individuals with deficits, open wounds, PVD, diabetes. And so, like I said, a lot of people with GBS do have sensory deficits. So it's really important to us to be monitoring this experience, maybe not go straight to 20 minutes right out the gate, check them after a few minutes to see how their skin is holding up. Also, client response is going to be different because each GBS is so unique. And yeah, that's phototherapy for y'all.
And we will upload all of these in the shell thingy, so you can look at them more in depth.
And for our orthosis, we chose an AFO. Now, another very beneficial orthosis to mention, it would be a resting hand splint during their acute phase, just to prevent contractures and to promote that functional positioning. But an AFO will assess GBS patients that are exhibiting foot drop. And so this would be something used, more during that, doing more transfers. And so what these AFOs do is they maintain a neutral position in your foot. These also can be used in rest too, while the client is in bed, but just keeps a neutral foot position, and it doesn't let your foot go into full plantar flexion. And then just a couple of precautions, you always want to monitor any sort of orthosis for skin breakdown, any shearing. And it also helps to wear some sort of sock with it, so you don't have that, that can help absorb any fluid, any sweat, any fluids. So you're not going to be chafing as much. And then you don't want to wear for more than 8 hours without a break. Another thing is weight fluctuations. Like, who knows if someone is very, due to their GBS, they may have a weight gain, and it's really important to monitor this because that AFO made specifically to them may no longer fit if they have some weight fluctuation. And then initially you just want to put this, orthosis on for about 30 minutes, see how they do those skin checks, and then increase your time slowly. In this case, while they're resting in bed to promote that neutral ankle. And also when they're trying to, maybe in therapy, or when they're trying to do some transfers. And it's really important with all splints with that low heat plastic is to keep them away from heat. Be in the car, near any heaters, any hot water, because they'll warp. And then you can just wipe it down with a damp cloth or an alcohol wipe. And there is our article talking about why AFOs are great.
And then I think the last thing we have is our concept, really just breaking down what we did in our presentation and what you would do as an OT if you had a client with GBS. So it's really important to know what phase they are in, knowing what where they are in their stage of recovery and the stage of the disease progression. So where they are really is dependent on what you can do as an OT. So I think a lot of it we've already discussed. I would like to point out, though, really that psychosocial can be in all aspects, all three phases, as well as occupational profiles as well. Okay.
Are we all done?
I think so.
All right. Thanks so much for watching, y'all. Good luck on the quiz.